Ladies and gentlemen, we welcome you tonight to the forum. On behalf of the Institute of Politics, I'm David Pryor, the director of the Institute, and on behalf of all of us here in the Kennedy School of Government family, we extend to you a very, very hearty welcome. We have an enormous crowd this afternoon. We have a superstar panel that will continue the forum's tradition of discussing the world's most pressing public policy issues tonight. Our discussion, healthier or wealthier, which comes first in the global era? Before I introduce tonight's moderator, please let me recognize 3 students at the Harvard Medical School who played key roles in conceptualizing, organizing, and promoting tonight's event. Erica Sager. Erica, where are you? Right here. Thank you, Erica. Ralph Vedders. Ralph, I know you're here. I've seen you there. You are right here. And Derek Willis. From North Carolina, I believe, Derek. I'd also like to recognize and thank the following organizations for helping to sponsor tonight's event: the Harvard Health Caucus at Harvard Medical School, the Center for International Development at Harvard University, and the Harvard Interfaculty Program for the Improvement of Health Policy and Systems. And now it is my very distinguished honor to introduce tonight's moderator, a man who knows a little bit about tonight's subject, Harvard University President Lawrence Summers. President Summers has just returned to Harvard earlier this year from Washington to become the what number president of Harvard? 27th. You're right. You get a $5 bill. He was a very powerful force in Washington, serving most recently as President Clinton's Secretary of the Treasury. In fact, on this $5 bill, his name is emblazoned across the front. President Summers served as Vice President of the Development Economics and Chief Economist of the World Bank. His history at Harvard is legendary. As a student, he excelled in the classroom. As a professor, he was equally successful, becoming one of Harvard's youngest tenured faculty ever. It is my great privilege to introduce a friend of ours, a friend of the Kennedy School, and certainly a friend of all of Harvard University. Ladies and gentlemen, President Larry Summers.
David, thank you very much for those kind words. Thank you all very much for coming. This is a subject, health is a subject of profound importance at a time when scientific progress is making it possible for us to do more and more with respect to more diseases, at a time when convergence and globalization provides great opportunity for improving health status around the world, and at a time when, for the first time in centuries, human life expectancy in significant parts of the world is actually falling rather than rising as a consequence of AIDS. The question of what can be done to improve health in the developing world is as morally and practically pressing as any other question facing mankind. To discuss it, we have a stellar panel of people who have approached these issues from a variety of different perspectives. Roberta Baskin is the senior producer for ABC News' 2020, is a Neiman Fellow this year, and has distinguished herself in many ways, including her work on globalization of the marketplace, particularly as it relates to trade and public health. Tim Evans is on leave from Harvard School of Public Health to serve as team director of the Health Sciences Division at the Rockefeller Foundation. He holds degrees from Oxford and McMaster, and completed a residency here at the Brigham. I should say, for those who don't know it, for several decades now, Rockefeller has been a leading innovator and driver of progress with respect to health in the developing world. Phil Musgrove is a principal economist at the World Bank, where he has worked in a number of different regions of the bank, particularly in the Latin American region, and over the last 2 years has served on detail from the bank to the World Health Organization. He has been very involved with the bank's effort to bring analytic rigor and a hard-headed approach to making sure that resources are used as effectively as possible for healthcare. Jeff Sachs is the Galen Stone Professor of International Trade and the Director of Harvard University's Center for International Development. He was recently appointed as an advisor to UN Secretary of General Kofi Annan on global poverty. He has advised innumerable countries on innumerable questions, and has most recently been centrally involved in the led the World Health Organization's report stressing the important impacts of health policy, not just on health, but also on the level of economic performance. Awash Teklahemanot serves as the malaria program manager at Harvard's Center for International Development. He has extensive national and international experience on various aspects of malaria, and was the director of the malaria disease control program in Ethiopia for 5 years, a program that was the largest in Africa with over 300 staff members. When I got here, I was told that I didn't have the easy task of saying, Roberta, now you have your 5 minutes. Jeff, now you have your 5 minutes, but that I was to lead an energetic and stimulating discussion on the topic at issue. Awash, say something from your experience in Ethiopia about this broad question, and in particular, what both Harvard and the broader public health community globally could do most effectively with current technology to reduce human suffering from malaria.
Thank you very much.
3 minutes.
It is a big question to answer. I think, as you all know, malaria is a very important disease. Not only Ethiopia, it affects about 90 countries. Close to 1 to 1.5 million die every year from malaria. So it is a real challenge and problem in Africa. When we talk about Ethiopia, the population is about 65 million, and 65% of those people are at the risk of malaria. So quite a number of people live at the risk of malaria. The situation is unstable, and therefore the people are predisposed to epidemics. When epidemics occur, literally they are explosive, just like fire, and a number of people are lost. Their persistent agriculture is also affected. So it's a very serious disease. What can the international community do? I think there is a lot the international community will do. Now with the Global Health Fund, it's possible to mobilize resources because the needs of the country and what it can master at a local level don't match. There is very shortage of funds, technical experts, and therefore I think Harvard will be instrumental in developing the capacities of national programs in order for them to be able to plan, to implement, and monitor their activities. Thank you.
Anyone else want to comment? Do you want to comment, Phil, on the bank's experience in a number of countries, particularly with malaria, but more generally?
The bank had the good luck to get involved in a malaria project in Brazil, which ended up, it wasn't planned this way at all, it ended up actually testing the changed approach to malaria that WHO and the Pan American Health Organization were pushing. And this turned out to turn a certain amount of conventional wisdom on its head. The old-fashioned way of fighting malaria was doing everything you could to kill mosquitoes, which outnumber us by at least 1 billion to 1. And there was not that much, it seemed, that one could do once people got sick, except help get them through an episode and hope that they didn't die. And most people don't die, but quite a few do. The change in strategy, which the bank was instrumental in helping promote in this case, was to concentrate a lot harder on treatment, in particular just to get people to go for treatment at the first sign of really high fever. It's surprising how often people get sick in malarious areas and don't know immediately it's malaria and don't do anything about it. And if it progresses to cerebral malaria, they may be done for. So the old story that an ounce of prevention is worth a pound of cure turned out not to be as true as we used to believe. It doesn't mean you give up on prevention. It means you concentrate it a whole lot more. You just can't kill every mosquito. And if the mosquito is where there aren't a lot of people, you don't care. And if it isn't carrying falciparum, you don't care. So we were able to show that in terms of cost effectiveness, changing strategy really could make a big difference. The cost of life saved came way down by focusing the prevention better and being a lot more aggressive about treatment. I assume that this is replicable in Africa. I don't know for sure. My own expertise is very marginal to this. But it was an exciting opportunity to try changing strategy without, this is important, without actually any technological advance at all. I mean, we're still killing mosquitoes the same old way and still treating people the same old way, but changing the balance actually matters.
Want to add anything?
Perhaps just, from the Rockefeller Foundation history with Fred Soper, who was the great eradicationist, and in the sort of link between health and wealth, I think if you look at Sardinia and Sri Lanka and other countries where eradication worked, there were very significant economic returns. I think the challenge in the context of highly endemic malaria, not epidemic malaria, is that you have to think about control as opposed to eradication. And the challenge of control is multidimensional and has to therefore take on strategies beyond prevention to include acute treatment. And therefore, the focus on acute treatment for children is certainly a very important complement to preventive strategies like insecticide-treated nets or local vector control within the household.
I would add a postscript, I guess, and that is that the sad report card of the media in covering this sort of thing, you hear about it at the Kennedy School at forums like this, but stories about malaria in far-flung places are not thought to be of interest in New York or across the country where they decide about what the coverage should be. And it's been exacerbated in the last 10, 20 years by the closing of foreign bureaus. The numbers are pretty bad. Half at ABC, 2/3 at NBC. And at CBS, where I was working during the 90s, it was fairly hopeless to even pitch a foreign story and get anybody's attention. It was like, how is this relatable to us? And of course it is relatable to us, and I think it took September 11th to make us look at the world, to focus on the world in a different way, in a new way. And, but at this point, the foreign bureaus have mostly been closed, and so you don't have reporters, experts in places around the world who speak the language and who know what the problems are and can translate them to America.
Think about opening the newspaper every day and the headline would be 6,000 people die yesterday of malaria, which is what you could have the headline every day, day in, day out, year round. You never read that headline. You don't even read the story once during the year, and yet we're losing that number plus like numbers to AIDS, and increasing, of course, tuberculosis and many other killer diseases. With malaria, it's quite stunning, actually, how even the control efforts basically disappeared for 20, 25 years. There was no funding. Awash has been a leader at WHO in trying to reestablish a scaled-up malaria control program, what's known as Rollback Malaria, which is a major thematic program of the Director General, Gro Harlem Brundtland, who's trying very hard. But even with that very big name and very big rubric, there's been almost no funding yet for Rollback Malaria. So when Awash mentioned this new global fund, which is something we hope you're going to hear a lot about, it's what Kofi Annan started last spring, the Global Fund to fight AIDS, tuberculosis, and malaria. We're hoping that for the first time there's actually some real resources behind this. But in much of Africa, there's been almost no control for a couple of decades. These countries have been in an economic slide. They haven't had the resources. They fired a lot of staff that used to clean gutters and take care of breeding sites in some of the places where we're working. And every sign is that the burden of malaria has been rising just along with the overall crisis of health in these countries. And if there is one pattern that's pretty significant, if you can get malaria under control, you get a real economic boost. And if you don't get it under control, it's damn hard to attract the tourists, the foreign investment, the other things that you need to make an economy go. And therefore, the places with this heavy burden of malaria aren't making economic progress either.
Let me ask you all to comment on something I think is very important with respect to the public policy aspects of all of this. And if I could illustrate, when I was at the World Bank a few years ago, Phil, working with you, and we were involved in working on the World Development Report on health, I went to an African country, but what I saw, I think, could have been observed in a number of African countries. First, we visited the hospital in the nation's capital, and there were 3 CAT scans, each of which only operated 4 hours a day because there was a shortage of trained people to use the CAT scans. Each of the CAT scans cost at that time a couple of $100,000. And then a little later that day, we visited a clinic in a rural area where they reused syringes because they couldn't get an adequate number of syringes to provide the injections that were important in healthcare. This was at a time when we already knew enough to know that that was a very dangerous thing to do. And people who are minded to do this kind of thing have done various statistical plots that suggest that it's not easy to find a close link between how much countries spend on healthcare and what outcomes they get in terms of life expectancy or infant mortality. What is the right balance for international agencies, for advocates, between urging more foreign aid around healthcare and urging that existing resources in national health budgets be spent in better ways? Are we confident that mobilizing more money in the ways in which it will actually be spent in actual countries will produce beneficial results? Someone?
Tough questions number 36, I think that one is. President Summers is being too kind when he says we work together. My boss reported to him. You have to understand. Every time this discussion gets going, everybody says both, of course, more money and also better use, and it's kind of hard to quarrel with that. There's a tendency, which I'd like to use this occasion to argue against a bit, which is to suppose that the big mistake, the big reason that money doesn't pay off better, is buying the wrong things all the time. And this is what the cost effectiveness argument tends to be about, that you should buy those things that get you the greatest number of life years or disability adjusted life years, pick the metric you want, per dollar spent. And I'm not against that argument. One wants to see money spent on things that pay off. On the other hand, if you push that argument too far, the government should buy everybody's aspirin because aspirin is unbelievably cost effective, and yet most of the world can afford to buy aspirin out of pocket. So right away you're led into thinking maybe this is a matter also of worrying about things a little less cost effective that are life-saving on the one hand, and worrying about the difference among people between those who can pay for something either out of pocket or through insurance and the multitudes who can't. And I think governments haven't got that as well figured out as they hope to, even though they will all tell you that their publicly provided health services are, of course, aimed at the poor. But the argument about which things to buy misses another great big issue, which this example of the CAT scans and the syringes brings up. It doesn't matter what you're trying to produce if you've got the input mix all wrong. If you have doctors standing around with their hands in their pockets because there's no equipment, or equipment standing around because there's no staff that knows how to run it, or it's idle because there's no spare parts, you're going to get the kind of situation that Dr. Summers describes and that you see everywhere. This happens at maybe worse in the poorest countries, but it's a constant refrain. If you don't get the input mix right, if you don't get the balance between doctors and nurses and syringes and equipment right, no matter what you try to do, it's going to come out badly and it's going to pay off rather worse than it ought to. And it is frustrating how that part of the argument gets hidden behind the questionable, which things should we be trying to do? No matter what you're doing, if you're doing it badly, it's not going to turn out terribly well. And here you have, I think, two problems that the world needs to work harder on. One is we think of people, medical staff, as an input to production, which of course they are. And we forget that they're the input that decides about all the other inputs. You know, it's doctors who make decisions about things like equipment. And if they decide those wrong, then they're screwing up their own opportunity to be an effective input. And the other side of it is the donors, who are much more willing to give away or help pay for CAT scanners than they are to wade in and try to fix the input balance on the other end. And this problem is very nearly universal. And it's the one respect probably in which the private provision of medicine does a better job. It may pick the wrong things to do. It may put the effort only where the money is, where people can pay for it. But it isn't as wasteful on the input balance, which is why those of us who bang our heads on this keep wishing that public services could have to compete more with private ones, not yield to them completely, but compete to the point of having incentives to be efficient on the input side. And then we could get together and talk about what we ought to do with those inputs. Pardon the sermon.
Two issues to follow up on that. One is just to pick up on the human resource input side, which I think is very often neglected and perhaps the most important part of any health system. Health is healthcare in particular, but health in general is largely dependent on human engagement of one sort or another. But it's not simply a national issue. If you look at the flows of health human resources globally, you see massive net transfers from the south to the north. The British National Health Services, expanding by 10,000 professionals. This means literally plane loads of nurses from Ghana going to the United Kingdom. And therefore, how can one expect to make greater investments in overseas development assistance when you're diminishing the human resource base that is going to be delivering or responsible for delivering the opportunity of increased.
So what should we do about that?
It's a global.
It's a troubling observation, and if you look, I dare say, if you look at Boston City Hospital at 2 in the morning tonight, you would find a number of people involved in treating patients there who had come to the United States from other countries that were substantially poorer than the United States. What should we do about it?
Well, I look at it in a unique way. I don't look at it as an issue so much as a story. I mean, you tell me about the CAT scans versus the recycled needles. I think what a great story. But It reminds me of a soundbite that I got from the owner of the Sublime factory in Pakistan when I went to do a story on child labor. Walked past the Uzis at the gate with my pictures that I had gotten across the street of children making soccer balls for our children here. And he said, "We don't use children in our factories." And I said, "No, across the street in the stitching workshops." He said, "No, we don't use children over there either. There are no children there." I said, "I just came from there. I saw the children." He said, "No, there are no children." I said, "I have pictures of the children." And he just sat down and he said, "Well, if it happens beyond our face." That was the quote that haunts me. And it's happening beyond our face. And I think that that's one of the big problems, is how to bring it as a story home to America. This was a story that was difficult to get a network to agree to send me over there, because who cares? These are children in Pakistan who are working there, as young as 6 years old.
Roberta, you make a powerful point about the need to dramatize and make clear to people what's happening.
To shine a light.
So it's not just a statistic, and I think it's a hugely important thing. I want to come back to, because I think it points up the fact that one has strong moral impulses, but it's sometimes hard to know what to do. So I'd like somebody else to speak to what should we think about doing in response to the observation that there is this south-north migration of skilled health personnel.
Let me take a shot at it. I don't know what to do, but there is always behind this a sort of low-level equilibrium. You look at the people, the medical staff who work in these hospitals that are so inefficient sometimes, and what's the story with them? They're drawing miserable salaries. And why do they continue to work there? Because they've got a private practice on the side in many cases, something which the nurses, by the way, usually don't have, which is why there are more plane loads of nurses than there are plane loads of doctors. They go to the public hospital because that's where money's been spent on equipment, and they often use it for free. And if they don't do that, they use it to recruit patients. They filter out the ones who have insurance or who have some money, and they say, "Look, I can only give you 5 minutes here, but come to my clinic in the afternoon, and I can give you half an hour if you need it." And so they're siphoning off some of the resources. But those resources aren't public ones if they're spent outside the public hospital. If it were possible to pay the private providers under some really strict regulation, really make them do a decent job, if there were enough money that everybody in the public service was getting decently paid and had less incentive to migrate, that might be a way out. And that would take more money, I'm sure. Because what you've got is a situation in which the public sector and the private sector play a game of I'll pretend to pay you and you'll pretend to work, and this is more or less what comes out of it. Now that would solve a little of it, and it would take some more money, and above all it would take a government that could actually pick the right private providers and not pay the quacks, which in some countries would be a problem. And then they'd have to come back to the nurses and do something about them, because the imbalance in economic opportunity at home between doctors and nurses is often very large. And if you don't have the balance there, what do you end up with? Doctors doing nurses' duties, or worse still, nobody doing them.
I think the story's a good one, but too good, because the basic issue at the core is poverty. And whether there's a CAT scan or not, the evidence is quite overwhelming that it's not that resources are wasted, but that the level of input in these countries is so tiny compared to need that one can't even get started. If you look at the level of spending, well, think about it very mechanically first. When we're talking about the poorest countries in the world, you're talking about places whose income levels in dollar terms is less than 100th of the United States. And you're talking about doctors, therefore, that might make 100th of the salaries that they can make abroad. Maybe it's a 10th, but the public services are strapped for cash, because when you're at $300 per capita, there's no way that out of your own resources you can mobilize anything like what you would for normal health care. So much of the world, about 1 billion people, are really living with almost no health care at all. And the evidence that we garnered in this commission report, and I like to be like Jay Leno at this point and hold up the book and tell you that you can download it from our website for free, cid.harvard.edu. It's the report of the Macroeconomics and Health Commission. We found that the level of spending in poor countries is about $11 per person right now per year, compared to about $4,500 in the United States. $11, we found out, doesn't go very far. It just doesn't begin to even cover the barest of the bare essentials, which is why millions of people die every year at the core, because they're impoverished. And what was interesting in the commission was that we started out for about a year in the debate, use it better, more donor money, use it better, more donor money. Then we did a very careful costing led by the London School of Hygiene. And at the end, everyone said, you know, it doesn't make sense to argue over this $11. You need $35 to $40 a year even to make the most basic stab at the most basic control of the epidemic diseases and other infectious disease and safe maternal health. And these countries, under any circumstances, will be unable to do it out of their own resources. So you need a lot more money. And we called for doubling or more the level of doctors' salaries, because that's absolutely required if you're going to keep any doctors there. And yes, for targeting. But my view is that so much of what looks like inefficiency or waste and so forth is basically what happens when you put no money through a system. There's nothing that can run. And so that is the wages of absolute poverty. And we shouldn't be surprised that when a place is at $300 per capita, people die by the millions. That's the basic fact. Then comes the question how to get out of it. And I guess one thing that we're arguing in this report is that the idea that you do economic reform and get out of it, then you can afford more, misses the point that as long as so many people are dying, there's so much disease around, it's not going to be so easy to get out of without some direct intervention. So there are at least two reasons to actually spend a lot more from the outside. One is that these countries are trapped in this cycle of disease and impoverishment. And the other is that when we think about it, I believe, as Americans, we're actually not too satisfied to have 8 or 10 million people dying a year. Maybe 25,000 a day is the true headline, dying of their poverty, when a few bucks from each of us per year could make a phenomenal difference. And I think that that's really at the core of this question about what to do, in my opinion. So I'm all for throwing money at problems. I think it's the right answer.
To say something about, Jeff, we might, somebody else may want to comment on this, we might get all the money you'd like, but the world being the world, we might not. So let's assume...
Nothing personal as you're being university president, but we were kind of hoping you'd stay as Treasury Secretary to get that job done for a while.
Well, we did our best. We did our best for the bank and for vaccine research and through debt relief while I was at Treasury.
I know you did.
There are elements. Suppose we had $1 billion more from the world of external funders to devote, not to this whole problem, but just in order to make our conversation concrete, to devote to issues relating to AIDS in Africa. And we could spend some of the money on making drugs available. We could spend some of the money on education. We could spend some of the money on a variety of specialized and targeted programs for sex workers. Since we're only talking about an extra $1 billion, if one of those activities really is higher payoff than the other, probably the right thing to do might be to spend the whole $1 billion on whatever was the highest payoff thing to do. I'd be interested in the members of the panel's views on, with $1 billion to spend on AIDS in Africa, where would you target the $1 billion? And I'm going to apply an absolute rule that is by invoking a phrase that's frequently used in our law school, which is you can't fight the hypothetical. So
Right.
it's $1 billion more in Africa to be spent on AIDS according to your best reading of the available evidence.
I think the best investment has to be investing in the maternal-child axis through maternal-child transmission prevention, but going beyond that to extend care to mothers so that you're not simply preventing transmission infection to children, but you're also ensuring an opportunity for that child to grow up in an environment where they have a mother that's going to live through their own childhood. And that means providing care to mothers.
You spend all the money on that rather than, I haven't followed this subject closely in a number of years, but rather than on education with respect to safe sex, rather than on specialized programs to control transmission at the truck stops, you'd spend all the money on the you'd put the focus really very hard on the maternal child.
Talking about East and Southern Africa, where the epidemic is largely concentrated in young women, most of whom are in their reproductive age of life, my sense is that that would provide the best combination of prevention and care in the context of the epidemic. And I'm only making one investment.
Bill?
I'd probably buy that too, although I know about 1% as much about it as Tim does. If you're in the early stage of an epidemic where it's very highly focused at the truck stops, then you throw your money there. But if you don't stop it there and it expands, you hit the point where that doesn't make as big a marginal difference anymore. And in a lot of Africa, that's already happened if, in fact, there ever was the chance to stop it there. It may be different in India today. You might want to put your money in a very different pattern. I think the difficulty about education is you're up against something that's never happened before in history. We've got a disease which could be, the incidence could stop tomorrow and the prevalence could stop in 20 or 25 years at the outside if people change their behavior. We know that. What we don't know is an effective way to get this across to everybody who needs to know it. We're obviously not succeeding as well as we'd like, although it's doing better some places than others. I don't think we know what to do with an extra billion at this, and what we do know is that the messages are often completely out of line with actually getting through to people. It is, a message isn't automatically heard. I remember being in Trinidad when they had their first AIDS case, and their first poster about AIDS was a lot of heads in silhouette looking up at the sky, and up in the sky were sharp triangles coming down on them like little pieces of broken glass, and underneath it said, AIDS, the killer disease. Well, if there was a message in that, it was carry an umbrella and you won't get AIDS. Their second poster showed a guy with his arm around his girlfriend on a park bench, and it said, AIDS, you're safer with just one partner, but it still didn't give you a hint why. It took them years to begin to get a message that anybody could actually understand as meaning, hey, this will kill you unless, and that's the only message that matters. Now, if we're so slow to get onto this, and the lessons are so slow to permeate a population, that's why I'd be scared of throwing $1 billion at it, even though if I knew if it would work, I'd put everything there and write off a certain amount of the current generation and try to stop this within the next decade or so. It's the uncertainty of it working. And in that respect, the only other disease, and of course it isn't a single disease, that's remotely like AIDS happens to be smoking, which could also be stopped completely with behavior change. And we're only making gradual progress on that one also.
Jeff?
Yeah. I am delighted by what I heard, and it shows how quickly the mood and the sentiment is changing, because while I like Tim's recommendation, the donor world hasn't put one penny towards that yet. They've started with MTCT, mother to child, not the philanthropies and not the foundations, but the official donor world. Sorry, Rockefeller has started something called MTCT Plus, which is exactly that policy. But the official donor world, just to frame this, that means the US government, World Bank and others, has not yet paid for one person in the world, out of the 65 million that have been infected by this virus, not one person after 25 million deaths to get antiretroviral therapy yet. Not one person, other than the single or double dose nevirapine or mother-to-child transmission, which is only on trial. The idea that adults should be kept alive has not so far dawned on officialdom, although it's coming fast, and I think the mood is changing very fast. So I would, if you don't let me argue the premise, I would say let's throw it all towards treatment. And then knowing that, they'll say, gee, we got to do something with the next billion for prevention. To be serious, you need all the parts to make any of them work, actually. We've demedicalized AIDS. We have therefore taken it out of the counseling, testing milieu. We've taken it out of the kinds of things that really could make a difference. We've completely neglected all the basic principles of public health, which is, in the US, for example, the treatment is secondary prevention. This is a standard way that CDC describes treatment as how to get people into voluntary counseling and testing. You know, just to conclude, 95% of HIV-infected Africans, it's estimated, don't know their status. That's a hell of a bad place to start to control a pandemic. And they don't go for counseling because it's nothing but a kiss of death right now. Not only is it stigma till the end of life, but it has no practical consequence whatsoever on the individual because there's no treatment. So somehow we've completely neglected the most basic things because we thought that so far that it hasn't been cost effective to keep an African alive at a cost of $1 a day. And that's just a bad calculation from a moral and a practical point of view.
I think if we think about sustainability, putting the 1 billion on one issue is not cost effective. Maybe we would prolong the lives of those people by giving them drugs, but then since the people are not well educated, they don't know the methods of transmission, we are going to replace them by another group. So I would say unless we are just looking only for a short solution, maybe to entice the donors, look what we have done now with a small amount of money. If you give us more, we will do a concerted effort in various directions. Otherwise, it will not be sufficient. If I don't want to challenge to ask for more than 1 billion, but if I was to decide, I won't even distribute it throughout Africa because we are not at the initial stage of the epidemic. It is already out of control. So it's not like for each country to test a little bit. I would concentrate maybe then with that billion on a few number of countries, especially in Southern Africa where it is very serious, and then demonstrate that this is doable. Another point I have is your observation of your visit is not typical only to the place, it is throughout. I have been in Africa all over, this is my job. And I don't know how many of you know about blood slides. You know, a small rectangular slide, if you want to treat, to diagnose malaria, you will put. There are countries where they have to break it into 3 pieces because they cannot afford one single slide. So the condition is very, very bad. It is true there are some mismanagements from the countries. For example, concentration on tertiary care may not be the right place. But when we also look at the health service coverage, most of the countries are 30%, 40%, and this is even nominal. Because when you go to the health services, to the clinics, most of them are maybe 6 months or 9 months out of drugs. So there is only a physical health center or the health post, but you don't have the right people and also the right drugs there. So I think this is where we go. Regarding this brain drain to the north, I think the best thing is the donors, instead of providing scans 2 or 3, maybe to collaborate with providing incentives so that these people would be stay at home.
Can I take a crack at your billion?
Yes.
I'll take half a billion, okay? And talking about prevention, putting it into education, give it to some documentary filmmakers also to bring the message home. I really think that, I mean, there is something to that. You do give money to the media occasionally for PBS documentaries, but to do something in country where you're not having, you know, posters up that suggest putting an umbrella up to treat AIDS. And I'd throw something else out, which is that I think that there is a role for corporate America to play in this. Corporate America goes overseas and hires workers in developing countries at below minimum wages of those countries. I went to Vietnam, I went to Indonesia to do stories on Nike where they were paying less than the living wage there in those countries. And then contrasted them with other companies. In the case of doing shoemakers, Bata, which is a Canadian company, was spending 3 times as much on wages for their workers, as well as providing health care. In Vietnam, Coca-Cola was paying twice the minimum wage and providing English classes and sales training. And so depending on an image that a company wants to have, they can do a lot in terms of providing health care and providing a decent wage so that people can pull themselves out of this cycle of poverty.
Larry? I'm going to take extremely brief interventions because I want to turn to the audience for questions.
Awash used a moment ago the word sustainable, which I'm kind of glad to hear was held off this long in this discussion because we hear it too often. But there's a point here that I think matters. For some purposes, we care very much about something being sustainable. But maybe in the case of fighting AIDS, and maybe also malaria, that's not the issue. The question is not, could the world afford X million or billion a year forever? We hope not to be in that situation. The question is, what would it take to get over the hump to the point where 2 good things would happen? One, a disease is under control, maybe not eradicated. We've only eradicated 1 so far. But under control so the cost of dealing with it's a lot less than it is at the peak. And secondly, so that the countries get the economic benefits from controlling that and other diseases and are able to spend more and do it better. We don't want always to be thinking sustainability. Sometimes we want the big push, and that's what a good deal of the argument of the macroeconomic commission's about. But then on the other side, if we succeed, there will be arguments about what's the right way to sustain campaigns, or we'll never perhaps completely lick the disease.
I'm going to turn to questions, but before I do, let me just make one observation, if I could. And that is that of all the many subjects that are thought about and studied in the world, the subject that we've discussed on this panel strikes me as one where the ratio of importance to the human condition to amount of thought that it receives from first-rate scholars is particularly high. By some estimates, more money is spent by the private sector on pet disease each year than on tropical disease. And the social scientific questions around the comparison of various resource uses, which do have enormous impacts, have seen very important work done by members of this panel and in other places. But the subject is a subject where we have an enormous amount to learn. And I want to commend the members of the Harvard Health Caucus for having brought focus to this important subject. And I want to commend them on the fact that over their 3 years of existence, they have in important respects done more to foster interdisciplinary collaboration and collaboration across the different schools of the university than a lot of administrators who've worked on the question a lot longer. And so all of us here are very grateful to the members of the Harvard Health Caucus, and we look forward to your continued attention to these subjects. I'm prepared to call on people to ask questions. Yes.
Hi, I'm Ellen Connerton. I'm a student at the Kennedy School, and I'm very pleased that you're talking about providing treatment to the women in these countries from the maternal and child health dynamic. and I'm looking at the topic today, healthier or wealthier, which comes first. I think AIDS, while I generally believe healthier has to come first, AIDS is a case where maybe wealthier can help increase health. And I want to talk about improving the status of women in these countries as a prevention strategy. One of the reasons the infection transmits isn't just that...
Could you ask, we're going to be very short on
Okay.
time, so if I could ask you to pose a question to one member of the panel.
Okay, to Dr. Sachs. Improving the status of women, improving their education, their ability to participate in the economy might also improve their ability to assert their right to use a condom during sex, which a lot of them just don't have. What's your sense on that? Do you think that's a strategy that we ought to try for?
Yeah, of course you're right, and when Larry was chief economist of the World Bank, he put a great deal of emphasis on girls' education as part of a health strategy as well as a development strategy. It's absolutely right. I want to speak on behalf of men, too. They should be treated as well. And there's no reason to triage men versus women, mothers versus children. We have enough money in this world easily. Tiny fraction of our money, we're asking for 1 penny out of every $10 from the rich countries, would scale up to millions of people on antiretroviral treatment, as well as control of the other diseases. So don't believe for a moment that in our 10 trillion US economy and 25 trillion world economy, the best the US can do is to make 74 cents of contributions in FY03 to the Global Fund. That's the nonsense. And that's what makes us, make these terrible choices.
My name is Mike Weissman. I'm a research assistant at the Kennedy School, and I guess this is something of a follow-up to what you just said, Dr. Sachs. I would characterize what we've had here as sort of a technical or economic discussion thus far, but I think we need to maybe take a step back and look at it more as the moral question. We just had a hypothetical discussion of $1 billion, but why not $50 or $100 billion? For instance, I mean, the U.S. military budget, I believe, is scheduled to increase $48 billion in the next year alone, and we don't need to have a discussion about domestic politics, but how do people in leadership positions like people here simply make the argument to broader numbers of people in industrialized, wealthy nations that this is an issue of concern? And for instance, the media, while I understand that there are pressures to show people what they want, I think also has a role to play in showing people what they have to see, whether or not they think they want to. So how do we do this? How do we address the moral question?
Roberta?
Well, I think that there's been a tremendous dumbing down where viewers, audience are not respected. And if you look at the numbers at NPR, they're the only ones who are gaining audience right now. The networks have been losing and NPR has been gaining because they give news in a very straightforward manner. And I think that, I know that at the networks, you're looking at minute-by-minute ratings, which doesn't do anybody any good. We've gotten away from the point of the news has been to give people, give them what they want to hear instead of what they need to know. And in the past, there was a real public interest function of news and local news and in network news, and we've shifted away from that, and I think it's shameful. And I hope that the message of September 11th will be a shift into more hard-hitting news and telling people more about the world, which has become a smaller place, and we need to know about it. So I think I think it's absolutely right for you to put that on the agenda here, the moral question.
Jeff, 2 sentences.
Yeah, when I testified in the Senate Foreign Relations Committee last week, this is going to be a long run-on sentence. The U.S. AID administrator for AIDS was asked the question by Senator Feingold, how much would it cost to scale up? And she said, that's an interesting question, Senator. We've never thought about that. We got a serious problem of engagement of the country, and I think we're going to have to find ways to get maybe 1 million people out to the mall to show them that America cares about this issue. And Bono is looking into ways to do that.
Upstairs.
Buddhi Malokuge, I'm from the School of Public Health in the MPH program. I'd like to say, Professor Sachs, your work in regards to redistribution of funds towards the countries in Africa is inspiring. My question is, given that the world's most powerful nation and wealthiest nation has political institutions that are comfortable with providing inadequate health access to up to 30% of its population, is there any reason to believe that appealing to countries on grounds of equity or need will lead to that redistribution of funds that you are calling for?
Yeah. You know, I don't know, but of course the incommensurability of what we're spending on our own health and what we're spending on the world is so unbelievable that you could do a lot on the bottom part of what the rest of the world without anyone even noticing. We're spending $1.4 trillion on our own health, and we've been spending, we spent $50 billion a year during the 1990s on AIDS in Africa. 50 million a year on AIDS in Africa. It's starting to scale up a little bit right now. It is not in the U.S. foreign policy interest, it's not in our security interest, and it's not in our soul's interest to go on in this complete befuddled ineptitude and lack of generosity. So I think something can be done, even with all the political problems that you point out.
Can I just
please
make a note that I think is helpful to strike, and I say this as someone who has worked very hard to promote increased U.S. spending on foreign aid to the poorest countries, debt relief for the poorest countries, support for vaccines, and it's a reading of the political process that might not be right, but I think it is. And that is that one has to overcome what is a deep skepticism about whether resources will be used productively or whether resources will be thrown at scary problems. And in making this case, and I know Jeff knows this and does it frequently in his advocacy, that pointing to this positive example where actual foreign aid translated into actual better health outcomes, a little bit of direct evidence of success is worth a lot of it's a scary, profound, unbelievable problem, and based on some calculation, a little bit of money would make an enormous difference. Whatever the people in this room may think, and whatever morality is, the people who vote the necessary resources believe that disease in less developed countries is a terrible, tragic problem. They don't believe that allocation of increased resources from the U.S. budget will make a significant impact on it. And so some willingness to engage effectively on the question of cost effectiveness as well as the question of morality is crucial, I believe, to actually mobilizing these resources in a successful way. And that part of the reason I've tried to steer the conversation a bit towards some of these questions of cost effectiveness is not because the technical aspects are most profound, but because the demonstration of real results for real money is, I believe, central to the political argument. Let me the question over here.
Yes, my name is Rachel Moreski from the School of Public Health. You somewhat answered my question, and it was very similar to Booty's question in the sense that given that the United States spends less than 1% of the GNP, and given President Bush's statement that he's not sure that the allocation of funds is worthwhile, and we're going to focus on bioterrorism and accesses, where do we get the money? The media, the money's not going to come from the U.S. government, and the media is not doing its job in getting money from the people, which even if it does, is there going to be enough donor source from the American people? And how do we mobilize that?
And we get the numbers right because they're very instructive. It's not that we spend less than 1%, we spend less than 1/10 of 1%.
Point one.
On all
Right.
official development assistance, we spend 1/100th of 1%. That's 1 penny out of every $100 of GNP on public health right now, global public health. So we're not even in the ballpark. And while all these issues of effectiveness are real, and they also can be answered because there are innumerable programs of success when you actually put the money and the effort into it, whether it's smallpox eradication or what's being done with polio or trachoma or leprosy or onchocerciasis or African guinea worm, or a dozen such programs right now, or the expanded program for immunizations in the 1990s, 80s, and 90s. There are innumerable programs. I'd ask the question politically, what's with the U.S. that we're doing a third, a fifth, a tenth what the European countries are? You know, they're looking at the same evidence. Where are we? We're just out to lunch right now. We just somehow have gotten incredibly lazy, I think, in the Congress in thinking about this, that I don't believe it's impossible to solve. So I wouldn't stop there. That's what you said is the beginning, not the end. It's a matter of bringing the evidence to bear and bringing the political power to bear also to show our elected leaders that we're just not the most selfish and stingy people in the whole world.
Tim?
I think Jeff mentioned onchocerciasis. It's an interesting example because that was the World Bank's first investment in health. And it was done in large part because a vector biologist by the name of René Lebert had the foresight to invite Robert McNamara to West Africa with his wife to visit a hyper-endemic village where blindness from onchocerciasis affected approximately 50% of the adult population. On the basis of that visual testimony, Robert McNamara engaged other members of the UN family to start the onchocerciasis control program. That sort of direct contact with people who are in a position to mobilize resources is perhaps one strategy. I would also suggest, though, that I think there needs to be a whole lot more creativity on the part of the American public in mobilizing a response, because there is a sort of a fallback, whinging, complaining notion, which is if government would only do more. There's huge wealth within the professional organizations, the nurses associations, the medical professions, the infectious disease specialists, the general internists, all of these paraprofessionals that could be recognizing their global responsibility towards the health of others and generating new programs and interests which politicians wouldn't have a choice about supporting. There'd be so much energy and enthusiasm behind them, they'd say, yes, good idea, we'll find a way to support it. So I think there needs to be a greater sort of grassroots demand, creative new ideas to get a much more commensurate public response to this, in addition to falling back on saying the government isn't doing enough.
I want to add a footnote to what Larry said earlier where he talked about the amount spent on pet diseases. The reason that onchocerciasis is being controlled is the good fortune that a drug, ivermectin, that happens to work for your dog's worms also happens to work for onchocerciasis. That's how the drug came about for veterinary purposes. And then a clever researcher discovered that it worked on the pathogen that causes African river blindness as well. So we even have there this remarkable fact of where you get the research actually spent right now.
So the pet money sometimes pays off.
Pet money occasionally can, right. It's not the most direct route.
No. No.
My name is Gabe Karajian. My question is to Awash. Incidentally, Awash is one of the most beautiful rivers in Ethiopia. And ironically, it is also one of the most contaminated areas of malaria. And might be with your name, Mr. Awash, I think you have a mission. Mr. Awash, I contracted malaria when I was 13 years old. Just camping with my family by the Awash River. And I remember the intensity of the disease during my stay in Ethiopia. And the fact that it takes only a couple of dollars to cure this disease. Starting from Haile Selassie's time, the malaria eradication program has been very strong in Ethiopia. However, we still see the country suffering from chronic, serious malaria problems with many thousands dying a year. Could you please tell me why has it been so persistent, this disease in Ethiopia, when the cure for it is so insignificant in money, in value? Thank you.
Thank you. I think, as he correctly said, malaria is a preventable and curable disease, and yet we have the problem with it. Particularly, Plasmodium falciparum is very deadly. If we start with children, after the onset of infection, within 24 hours, if they don't get some clinical support, the disease progresses into severe malaria, and the probability that they will make it is very, very low. But again, it is an issue of resource. The budget per person per year in Ethiopia for malaria control is about 8 cents. Because if the total budget for health is not $11, $11 is 80 birr, we are talking about maybe $5. So when the health budget is 8, then the share of malaria is about 8 cents, and there is very little you can do. And particularly what is hurting is, as you know, if you have been to Ethiopia, 80% of the cases don't come to the health services. On top of that, this is complicated because of drug resistance now. The anti-malaria drugs we have are not effective. The cheap drugs, chloroquine is out now. The second generation of drug is not working. So the effective drug that we are going to have now is in the order of $3 to $4. So I think I am painting not a good picture unless there is a substantial mobilization of resources to develop the capacity and also to extend the coverage. The point mentioned earlier was very relevant. The community-based intervention is one of the solutions where we have to go into the communities with simple technology in order to be able to treat the cases as soon as possible.
We are running short on time, so I'm going to be ruthless about insisting that the questions and the answers be short. Yes.
The question is short. My name is Sam Airy. I'm at MIT down the street. Change of topic a little bit, maybe for Philip or Jeffrey. There's been some discussion in the development context recently about the sort of relative merits of short-term versus long-term projects. On the one hand, short-term projects are more politically feasible to donor organizations or foundations or governments. And on the other hand, some people argue that in development, you can only achieve something of worth if you put in long-term effort, 10 or 20 years. How does this play out in international health?
Philip.
Depends what your problem is the easy way out of an answer. Most investments in the world last a long time, but they take a fairly short time to build, and we don't worry about that. The question is what you got left at the end of the short term. I think the real argument is over what we keep referring to here, capacity building. That's kind of hard to do on the fly. It takes some time. And it takes not giving people just a training course and then abandoning them to hope that they'll be able to apply what they learned. They've got to have resources to work with after they've learned something. That, I think, is where the crunch comes. But highly specific project interventions to change the way you fight malaria, to build some more clinics, there's no reason those can't be relatively short term if the people you're doing it for and with can take it over after that. I think what's gradually happening, I'll try not to be too long, Larry, is getting away from the idea that countries are poor only because they don't have enough capital. I'm older than most of you, and back when I studied development economics, the big scarcity was capital. Well, it's still capital, but much more of the capital is carried around in here than used to be. And as we get into what people know and what they know how to do, this problem of not just building something and walking away does become more acute. And yet, from all we've been hearing today, the simple physical investment in lots of things, the provision of very short-term stuff, like every year there should be enough glass slides and there should be enough syringes, those don't require very long buildups at all. It's getting the ideas across and people trained and then the resources to use what they know. Because without that, all training is a complete waste. Over to you.
No, let me go to the next question.
Hi, my name is Tariq Yassin. I'm a sophomore at the college. This is a question directed to Professor Sachs. I believe the gentleman from the World Bank brought up the public versus private sector debate on whether is more what is more effective, the private sector or the public sector. The public sector often being criticized for lack of efficiency. I was wondering if you had any thoughts about where aid could be used most effectively, given there is a scarcity to the aid right now.
I don't think there's any doubt that the public sector has to finance the great proportion of what needs to be done, because poor people can't do it on their own. It's going to have to come as transfers from the public sector. Some of it needs public sector delivery when it's this so-called public goods, things that individuals or their doctors or their health providers can't do on their own, when it's control of the environment or a campaign of disease eradication, or generally a lot of infectious disease control requires a public effort rather than just individual efforts. Even the use of anti-malarial bed nets is effective only when it's very high use within villages, which means not individual decision-making, but group decision-making. So in general, I'm very sympathetic to the public sector in all of this. Though provision of the services can often be from all sorts of different groups, NGOs, church mission hospitals, community-based organizations, private sector, but we need public funding from the donor side and running through often the public spending within country as well at various levels. This won't be solved by private action alone and by individual action. There are too many poor people that need direct provision and direct help.
Phil, you wanted to make a very brief comment.
Yeah, very brief one. One of the problems, which we haven't mentioned, is that for most poor people, the public sector is the only possible way to get away from out-of-pocket spending. We've been talking about how little spending there is, but those are averages. 80%, 70% of all health spending in most poor countries is out of pocket, and it isn't spread 8 cents or 10 cents each. It's catastrophic $10, $50, $100 for a family here while their neighbor gets spared. The only way out of the impoverishing effects of that is probably through public spending, because insurance just isn't going to reach these people. I mean, what can you buy for $1 a year of insurance? You can buy the insurance company covering you for 80 cents worth of coverage on average. It's not worth it. If you want to look further into this, I'll put in a plug for an article with a couple of co-authors that just came out in the most recent WHO bulletin, showing that the world's got it exactly backwards. Public spending is highest compared to the total in the countries where it's needed least, where most of us can afford a lot of it privately through insurance. And it's lowest exactly where it's needed the most. That's what we'd like to try to reverse.
Yes. Over here.
I'm Eduardo Pesqueira from the School of Public Health. We've heard from the members of the panel where they put the money, if they had $1 billion to put in the money, to put like in sub-Saharan Africa, where the AIDS epidemic has very peculiar characteristics. Where would that money be better spent? In areas like India, where the epidemic might be heading towards the same pattern, but it isn't there yet.
I'll let people give one-sentence answers to that.
Put a lot more of it still on the sex workers because it hasn't exploded so far. Full stop.
Put it on the political leadership to recognize AIDS as a veritable threat.
Prevention and treatment.
There's no verb in that sentence.
I'm instructed to be brief.
Take a final question over here.
Thank you. I think I'll address it to you then, President Summers. It's good to have you here and hope you make it a regular habit to come and visit more often. I think it was Mr. Evans that brought up the issue of the flight of, the trained nurses and doctors going, the Ghanaian nurses going to London and so forth. And you, President Summers, asked the panel, sort of specifically what would do, and I think it was only Mr. Tekel-Heimanot who addressed it to some extent. So perhaps I'll put it to you, and I'd be curious to hear if you have any thoughts about how that issue might be addressed.
Look, I think it's a very profound question about the way the world works now, which is the flow of human capital is from south to north, and the flow of physical and financial capital is from south to north. It's very different from the way globalization operated historically, and there are many reasons for it. My own sense is that the only enduring, credible way of addressing these imbalances is to create an environment in developing countries where capital wants to remain within them. That you can't lock it out of industrial countries, you can't lock it in developing countries, and so it really goes to the environment. And if there were syringes in medical clinics, if there was the capacity to pay nurses in a better way, you would reduce that propensity to migrate. And I think that has to be the best strategy. But it does go critically to what I think we do need to think more about, which is not just mobilizing more resources, as essential that is, but making sure that those resources are actually used to do the kinds of things that were discussed on this panel, rather than to provide bad surgical care to the children of the elite in the single urban hospital in the capital city, which is too frequently the pattern in these instances. And the question of the use of resources is an effective one as well. Let me thank all the panelists. Let me thank the Harvard Health Caucus for having convened us. Thank you all for coming, and encourage all work at the university that addresses what I think is an enormously important set of questions. Thank you very much.
Good. That was fun. Absolutely.
Oh.